there was a big announcement from FDA. One of the weight loss drugs was removed from the market by its manufacturer, Abbott, after an FDA panel recommended severe restrictions. And that will lead us to our number one pick in JAMA of what's left in the field of weight loss. But beginning with the number three pick this week is a study in JACC that looked at calcium scoring. This has been something that a lot of people have hesitated about, wondering whether it would be helpful. Is it additive? Is there too much radiation? But multiple studies have begun to really reaffirm its value in reclassifying patients. And this week in JACC is a paper from the Rotterdam study that looked at over 2,000 asymptomatic patients where they had all the traditional risk factors and found that with calcium scoring, they reclassified over 50% of the patients. So an enormous change in what you would consider a patient's risk if you add calcium scoring to the mix. They found that an Angston score of less than 50 was a low-risk group and greater than 600 was high risk. And so something I think worth re-looking at as something to help risk stratify otherwise asymptomatic patients. At the number two spot this week is a fascinating trial that looked at pharmacists assisting in the management of hypertension. This is something that also has had some hesitation, allowing pharmacists to assist in prescribing medications, but now has been subjected to careful trials. And so reported in the archives was a cluster randomization of 179 patients, half of whom got their usual care with primary care physician managing hypertension, and the other half who had pharmacists assist in evaluating for barriers to taking appropriate medication and adjusting it, and assistance in actually adjusting the antihypertensives. All of that could have been overridden by the primary care physician if there was some question. But they found a huge difference in blood pressure, almost 10 points lower in the pharmacist-assisted management strategy. And so this is a modest-sized study, but one that reaffirms the fact that having additional members of the healthcare team with careful follow-through on treatment plans can be very, very helpful. So at the number one spot is what's left in the management of obesity. There are very few drugs with removal of sibutramine due to the increased cardiovascular risk that was seen in the SCOUT study. There's more information about that study on Cardiosource. So for severe obesity, bariatric surgery has looked very helpful, but obviously is a major procedure. And of course, there's lifestyle with diet and exercise changes. And so this was subjected to a randomized trial with intensive diet and exercise with early exercise as part of the initial management versus delayed start of exercise. And not that surprisingly, but nice to see in a randomized trial, was that when starting both diet and exercise together, one was able to achieve much greater reduction in weight, on average a 10% reduction in weight in these severely obese patients when using the combination. And so this is certainly something that is our frontline therapy and something that we have to push through more aggressively. I did hear at the European Society of Cardiology meeting that in Sweden, physicians are allowed to prescribe exercise for stable outpatients as a recognition of how important lifestyle changes can be. So with this week's Cardiology Countdown, I'm Chris Cannon.